Hey, it's Ray. In times of uncertainty, it's easy to feel overwhelmed. And that's why over the next few weeks, we're revisiting 3 conversations that can remind you on where to focus your attention. We want you to focus on the things that you can control, and frankly, on the things that are going to help stabilize your finances. I'm talking about things like maximizing every dollar you can get with best-in-class referral management. I'm talking about how to manage hospital capacity. And I'm talking about what happens after a patient leaves the 4 walls of a hospital and how post-acute can be the right kind of partner across an episode of care. These conversations are all about the operational excellence that is within your control. And frankly, they're areas where we want you to act and act now. These episodes offer the practical insights to help you retrench, to refocus, and lead with clarity. Let's dive in.
We're talking about delivering care in the most appropriate setting and safeguarding acute level resources for acute level patients.
From Advisory Board, we're bringing you a radio advisory, your weekly download on how to untangle healthcare's most pressing challenges. My name is Rachel Woods. You can call me Ray. We've said it before on this podcast. Hospital volumes are back, and that means that managing the acute care operating model, things like throughput, patient flow, length of stay, is again top of mind for healthcare leaders, if it ever even left. Improving hospital capacity is not a new problem. And yet, there hasn't been an industry-wide consensus on how healthcare leaders can best hone their acute care operating model. I know these things are hard, but today I want to dig deeper into why capacity and length of stay remain persistently difficult problems to solve. This week, I've invited Advisory Board's Isis Montero. She spent the last 8 months talking to 45 healthcare leaders across 9 countries. In fact, Isis and her team identified, and I'm not kidding here, 124 individual root causes of high acute length of stay. Don't worry, we're not going to give you a to-do list 124 items long. In fact, we're going to shift your attention away from the never-ending to-do list and towards addressing the structural barriers that keep hospitals from reaching their full potential. Isis, welcome back to Radio Advisory.
Thank you so much. I'm happy to be here.
I feel like you have been on tour, Isis. Has it felt like that to you?
Yeah, I'd say so.
Not only have you been on tour, you have been on a global tour. Maybe it's not, your era's tour or your Renaissance tour, but you've been going on a tour trying to understand acute care operating models. Definitely not the same as Beyonce or Taylor.
Not quite that.
But in all seriousness, you have been out there really trying to learn about different approaches to operational challenges, throughput, length of stay, capacity, these tried and true hospital-based issues. And you've identified a lot of problems that contribute to ultimately pretty high length of stay. Okay, so we know what's going wrong. Do we have any idea of what's going right? Did you come across any big solutions that we should just name from the outset?
Yeah, so actually one of the biggest takeaways from this research is that systems are really not leaving a lot of easy wins on the table. We actually did a survey where we found that there's an average of 14 patient flow improvement initiatives that are happening concurrently across a single organization. So it's really not for lack of trying or a shortage of ideas for how to improve length of stay. To give you some examples here, we heard things like creating discharge lounges for patients that are medically fit for discharge and are awaiting transportation back home or to their next site of care, or doing asynchronous discharge rounds so that patients are still being evaluated by their entire care team, but that's not happening simultaneously. So even implementing command centers, right? And even that, while it does help to improve visibility, which is increasingly critical, is not a silver bullet solution. So that's the point here, right? Is that there's no one single tactic that's going to be the end all be all for the capacity challenges that systems are facing today.
I had a feeling you were going to tell me there's no silver bullet. I did not think you were going to tell me that the average organization has 14 different initiatives going on at the same time. I'm going to risk asking a ultra simple question here.
Go for it.
You just said there are no easy fixes, but just humor me. If the problem at the end of the day is capacity, Why isn't it the right answer to just add more beds?
Expanding your bed supply is not necessarily going to unlock additional capacity if you don't
Hmm.
have the workforce to staff those beds, right? And while the outlook has improved, staffing is still insufficient to meet patient demand or to be able to capitalize on the volumes that are returning. And this might not be true for everyone, right? Maybe the right answer in some contexts is to build or buy. But while that may help to alleviate capacity challenges in the short term, that's not going to be the answer to achieving long-term sustainability.
And I guess comes back to the idea of why there are so many different initiatives happening at once, because even if you add more beds, that doesn't solve the entire problem because you need to worry about staff. You need to worry about the right nurses, the right level of those nurses, and so on and so forth. I can't help but still think about all of the different tactics that hospital leaders are running at to solve this problem. And it sounds like they're not actually making that much of an impact. Why aren't these tactics making a dent in addressing length of stay?
To echo the point that you actually just made, when you're doing so much simultaneously, it's really hard to coordinate across all of these efforts or to identify what's working within pockets of the organization to be able to scale that out across the enterprise, right? So that's one challenge, just how difficult it is to scale out these capacity building solutions. The other challenge is a when in doubt, admit, or when in doubt, don't discharge culture that keeps patients in beds for longer than they need to be. And the third is a limited influence over factors outside of the traditional remit of the hospital, right? So things like a shortage of beds and staff in post acute or long term care, or even patients' unmet non clinical needs that might end up driving downstream utilization.
This is interesting to me. You found 124 problems, but what we're not going to offer is 124 solutions or 124 tactics. In fact, those three things that you just mentioned, these are entrenched systemic barriers that make it really difficult for hospitals to make an impact on length of stay. So let's take them one by one. And I'm really glad you started with scale, right? It sounds like we're at this spaghetti at the wall phase, trying to improve hospital capacity, trying to improve length of stay. And it's a big problem if we can find something that's working, but we can't actually scale that across the health system or across multiple hospitals. How do we overcome that challenge?
So I actually have an example of what good looks like from an organization in Australia, Gold Coast Hospital and Health Systems. So a little bit of context here, especially if you're not in Australia and you're wondering, okay, how is this relevant to me? I think that Gold Coast is really a microcosm of the demographic challenges that a lot of our members,
Mm,
including in the US, are facing. So Gold Coast population exploded over the last decade, and that's been fueled in part by new retirees
mm.
that are migrating to the area, which means that their overall population is also aging. And we did the math because that's what we do. And we figured out that if Gold Coast was going to try to increase its bed supply to the OECD average, which is 5.04 beds per 1,000 people, to serve their geography with its population growth, they were going to need to build the equivalent of 8 more mid sized hospitals by 2040 or add almost 5,000 beds.
Oh my goodness. But they weren't going to do that.
Yeah, we're going to do that. That's just not sustainable or feasible, right? So, in the face of all of these pressures, over the course of 5 years, they gradually built out this foundation for a system wide capacity management approach. And this evolved creating a centralized coordination hub with a command center and later pulling in critical partners like the ambulance service to optimize patient flow decisions.
Hmm.
And this laid the groundwork for the stuff that they did in 2023, which is to create their patient flow steering committee. And this patient flow steering committee is their centralized capacity improvement function, which they've housed under their strategy, transformation, and major capital division. This committee is responsible for identifying where the most impactful opportunities for improvement are, coming up with the solutions, testing them, and socializing those solutions across other clinical areas.
Hold on a second. You've said a couple things that have perked my interest. You said decade, you said 5 years ago, and then you said they set up this centralized improvement team that's totally dedicated to testing, coordinating, scaling the actual problem we're trying to solve here in
Mhm.
2023. How long ago did Gold Coast do this?
Yeah, so this is an effort that's been, to your point, like a decade in the making, right? And I think it illustrates just how difficult it is to resolve the structural challenge of scaling out solutions.
It also is the benefit of looking globally for
Yeah.
solutions, right? What you said is that what was happening in Australia in 2016 is what's happening in America today. So US health systems can actually learn quite a bit by looking at challenges abroad, in this case, looking at Australia.
Yeah, actually. And thank you so much for making this point because I cannot miss the opportunity to get on my soapbox about this. As someone that's worked more closely with international organizations, I'm a really big advocate for systems looking to other jurisdictions and learning from their peers abroad, right? Because I think systems have more in common in terms of the challenges that they're facing and the solutions that they're looking to than it might seem on the surface. And while you might not be able to copy and paste exactly what somebody in another country is doing, there are certainly approaches or behaviors that are worth adopting or at least considering in our local context.
We love soapboxes on Radio Advisory. So I'm actually going to ask you to stay on your soapbox for a minute longer. What are the key lessons that US healthcare leaders should take away from this particular example with Gold Coast?
So I think the two things that I highlight here is the way that Gold Coast has married strategy and operations. So I mentioned that they house this patient flow committee within their strategy, transformation, and major capital division. And this is really important because this is what allows the team to tap into and leverage resources like data analytics, IT support, project management
Mm.
expertise, and a whole network of clinical experts that are typically safeguarded for transformational projects.
Hmm.
And this to me like really illustrate what it looks like to elevate capacity building from being a clinician's side of desk work to a
Yes.
transformational objective with institutional resources behind it.
Wow, I love that. And that is the only way that you're going to take pilot projects, things that are done in a handful of places, and actually scale them across a hospital and across an entire health system, an entire ecosystem.
Absolutely.
That was only one of the structural challenges that you mentioned. Tell me about this other one. You called it the bias of defaulting to acute care. What does that mean?
Yeah, so it's a culture problem among providers where the default is to admit patients, right? And that's contributing to a systemic issues when it comes to managing length of stay.
When did this bias kind of come up? Is this a new problem?
I think that it became something that we really had to lean into during COVID, right, in order to
Mm.
protect our patients. But it's something that we now need to start to reconsider as we're experiencing more of these capacity pressures more acutely.
And I'll say I've heard this in my travels, right? The when in doubt, admit, right, kind of tendency that folks have that, to your point, I think comes from COVID, right? The fact that we had this acute, really complex, really scary moment just in the last 5 years. But there are other trends that added to it. I'm
Yep.
sure the kind of workforce crisis, the fact that we don't have the same level of education and expertise spread evenly across, particularly our nursing workforce, can lead us to default to this acute care bias, as you've said. But let me put my cynic hat on for a minute. At the same time, we're also talking about how hospitals need to balance the fact that they've got this aging population, this population that's older, that's sicker. I've also shared that we're dealing with a sicker, younger population. So I just want to push, is it really the right answer to shift away from our default to admit culture that's risen over the last 5 years?
Yeah, I'm really glad that you raised this point because we're not talking about abandoning patients, right? We're talking
Mm,
about delivering
mhm,
care in the most appropriate setting
mhm.
and safeguarding acute level resources for acute level patients. And that requires us to think of the acute setting as only one part of and not the entirety of the care continuum.
Hmm.
Systems might default to treating or keeping patients in the hospital when ideally the default should be whatever the most appropriate care setting is, even if it's not in a hospital.
Okay, so you've won me over. This is definitely a problem, but it is a problem rooted in culture. How do you actually change the mind of providers who've been operating in this model for the last several years?
Yeah, this is not easy, and it's something that takes time to do well because doing this well requires you to address the underlying challenges that prevent clinicians from adopting new models of care. right? So in some instances, that might be clearing up any confusion about who can be treated in alternative care settings or addressing their fears about patients not receiving the right level of care in the alternative setting. So I do have an example from another international organization. So Pennine Acute Hospital Trust, which is a health system that's based in the UK, they had an urgent care facility, but they still had patients who could have been safely treated there still presenting to the ED. And
Hmm.
inappropriate ED presentations is something that a lot of systems are struggling with, and something that our
Oh,
research
yeah.
suggests is actually going to get worse with time.
Hmm.
And Pennine realized that part of the reason why their urgent care was being underutilized is because it was hard for clinicians and patients to know or to keep track of all of the conditions that could be safely treated in their urgent care center. And so patients kept showing up to the ED and clinicians kept admitting from the ED instead of referring patients to the urgent care center, which was the more appropriate setting.
I can see the problem. How did they actually solve it?
Yeah. So what they actually did was create a short list of exclusion criteria for urgent care, right? So instead of people having to remember a laundry list of conditions that can be treated in urgent care, clinicians and patients now know that the default is urgent care
Hmm.
unless they meet one of 5 exclusion criteria. So this really flips the decision, right? From should this patient go to urgent care to why shouldn't they?
Hmm.
And now, because you had more and more kinds of patients that were presenting to urgent care, have to expand and adjust the staffing. And one of the changes that they made was to actually install a senior decision maker to
Hmm.
manage this wider range of patients.
And I'm sure to also help staff get more comfortable with this new model, which is
Yes,
an
absolutely.
important feature in culture change.
Mhm. And to that point, they also have a rotating member of the acute medical consult team that's there every day to provide additional specialist support and additional guidance.
We'll be right back with more radio advisory after this short break.
To stay competitive, you need to be able to compare yourself to other hospitals on cost, operations, and quality. Advisory Board's Hospital Benchmark Generator lets you compare your hospital's performance on financial, operational, and quality metrics with cohorts of similar hospitals. The tool uses Medicare data to give you easy access to the numbers you need, down to the service line or even MSDRG level, so that you can better identify areas for improvement to manage costs and improve quality. Like all of our data tools, access is included with your research membership. Click the link in the show notes to access the tool.
You're listening to Radio Advisory. I'm Ray Woods. At the beginning of this conversation, Isis, you outlined 3 systemic barriers for managing length of stay. The difficulty in scaling successful initiatives, we covered that, and the pervasiveness of this acute care bias, which we just talked about. The last one is post-acute capacity shortages. And I'm going to admit, this last one seems a lot harder for health systems to address because they just don't have control over what happens in post-acute, at least in most cases.
Mhm.
Again, I'm going to ask, is there a simple answer here that we are overlooking? Does this mean that hospitals should be owning and operating post-acute care facilities?
So I'm going to caveat my answer by saying that there may be some exceptions to this just to cover my grounds here. But most of the time, the answer is going to be no.
Hmm.
Beyond the financial burden of owning and operating a SNF, which for a lot of systems already makes this a complete non starter, you're
Yes.
also facing a slew of regulatory barriers, staffing challenges, and a lack of expertise about how to run and to operate the SNF.
Okay, so then we really saved the most difficult problem for last. I mean, what are health systems to do here? What approaches are you seeing in the market to manage the kind of post-acute throughput problem?
Yeah, so there's been some experimentation here, right? From sniff at home models, which are still
Mhm.
very much in their infancy and face the same kinds of regulatory and reimbursement challenges as acute care at home models, to partnering with or buying hotels for patients who are medically fit for discharge or awaiting transfers.
Oh, wow.
Now, But I really think that the biggest and most scalable opportunity for health systems is in bridging expertise and staffing gaps across their post-acute partner sites.
Tell me more about that.
Yeah, so something that we're seeing more and more organizations do is deploy their own team of nurses and geriatricians and sometimes other specialists to go to SNFs or to residential aged care facilities to deliver in-person acute level care to patients in order to prevent emergency department utilization or readmissions. In Australia, of course, I have to lean on my international examples here, but these are called geriatric flying squads. But you can almost think of these as kind of an adaptation of something like a community paramedicine program.
Or it's like they're doing rounds. They're just doing rounds out on the road.
Exactly. Yeah.
Geriatric Flying Squad is a much cooler name than just sending rounds. I'm a little bit surprised that you haven't brought up the role of technology, right? If I think about the first two systemic challenges, culture is not one that is easily solved by tech. Neither is scale. But this last one is a little bit more about workforce. Why aren't we running to tech, to AI, pick your buzzword here, to help health systems make headway either on this last issue or just on length of stay in general?
I'm glad that you brought this up, and I figured that this question around AI and tech would be coming. But what we found is that organizations are really using AI to do things that they were already doing, but perhaps a bit more efficiently, right? Like using AI to improve admission or bed placement decisions, for instance. So it's still bed air traffic control. It's just AI-enabled bed air traffic control.
So it sounds like more of the tactics that we're saying are not bad tactics. They're still useful. They're just not going to solve these systemic problems. Those are the ones that can be replaced with technology, but you also have to deal with these entrenched systemic issues if you really want to make a move, make a change on length of stay.
Yes, to your point about workforce and technology, and specifically in this point around how do we partner more effectively with our post-acute care partners, we actually came across a really interesting story from Canada, this time from Quebec, a hospital called Jewish General Hospital. They're using virtual reality to provide remote specialist support to caregivers in long-term care sites.
Whoa.
The staff at the long-term care facilities that are wearing these VR goggles, which are feeding real-time audio-visual information to nurses that are sitting in the hospital, and nurses can help assess the patient's condition and help the caregivers make better decisions about the patient's treatments.
Great example of technology making an existing solution better. This is like a souped-up consult. Isis, we've covered a lot of ground, but I have to imagine you have a lot more that you could offer to our listeners to help them with length of stay, with capacity, with their hospital operations. Where do you want our listeners to start?
So we do actually have a landing page for provider operations. And within that landing page, it's going to be all of the resources that the advisory board has published over the past couple of years, not just from this research cycle, but in the recent past as well, that are still going to be relevant for health system leaders today.
We'll add those links to the show notes. Isis, thank you so much for coming on Radio Advisory.
Thank you so much for having me, Ray.
Look, this was a conversation totally focused on operations. And maybe you're thinking, this isn't the coolest, sexiest story in healthcare. But I want to remind you of an episode that Abby did a couple of months ago. It's actually one of my favorite episodes we've ever done. And it's all about the new mandate for health system growth. And one of the things I learned from that episode is how important it is to focus on these fundamentals, to focus on the operations. We can't afford to get these things wrong. So remember, as always, we're here to help. Next week on Radio Advisory.
Hospitals and post-acute organizations can sometimes find themselves at odds or thinking negatively about the motivations of the other. And I think the more we can break that down and the more that we can foster that collaborative environment, the better it's going to be for both of those types of providers, as well as for the patients and the communities that we serve.
New episodes drop every Tuesday. If you like Radio Advisory, please share it with your networks. Subscribe wherever you get your podcasts and leave a rating and a review. Radio Advisory is a production of Advisory Board. This episode was produced by me, Ray Woods, as well as Abby Burns, Chloe Baxt, and Atticus Rosh. The episode was edited by Katie Anderson, with technical support provided by Dan Tyag, Chris Phelps, and Joe Schrum. Additional support was provided by Leanne Elston and Aaron Collins. Special thanks to Paul Trigonopoulos. We'll see you next week. Oh, you can stop recording now.